All right. Um, Dr. Callahan, how are you doing with setup? Are you almost about ready?
Yeah, I'm ready to go.
Oh,
So
great. Okay,
I think
well,
we're ready to
I just wanted to introduce you. This is everyone. This is Dr. Callahan, partner with Gobisi Shoulder Institute, and director of the Cleveland Hip and Knee Institute as well. He's going to here to talk to us today about reverse shoulder replacement. What are the indicators for that? PT and just the surgery and procedure itself. So please mute yourself when you enter. I know we're going to keep getting people logging in the next few minutes. Dr. Callahan, I'll make sure everyone's muted and the video's off. And then he will do a Q&A after his talk. And if you could use the chat feature at the bottom of your screen. I think it's under apps now that they upgraded it. No. Where is the chat feature? And if you want, you can unmute yourself or use the chat feature that you're seeing at the bottom of your screen to ask questions at the end.
yeah.
All right. So I'm gonna mute myself and let
I
Dr.
have a
Callahan take it away.
question. I have a question.
Oh, okay.
So
How do
we'll
you,
if you enter into the chat box any of your questions and try not to use the audio because it'll be kind of hard to do like verbalized questions. It's probably the best function for this webinar in this format. So if you can direct it, and Kelly will be paying attention the whole time. She'll
Yes.
answer any type out, even technical questions. She can work through with you through that chat box. It's we've done a few of these now, and it can be really disruptive if we're trying as I'm trying to present. I'd like to say that I'm an orthopedic surgeon, but I'm a man first, and I can't focus on more than one thing at a time. So if you're asking me questions and audio is going on, and I'm trying to do my thing,
yes,
can't do it. Like in surgery, I got the blinders on. We're just doing surgery. That's it. You can't ask me. So in all seriousness, if you could just use that chat function, that's real helpful because what it'll do is it'll allow us to engage with you without disrupting anybody else and then trying to hear it. And if everybody's talking, it's very difficult to hear what's going on, as you can imagine. So at any rate, I'm going to get started here. Let me get my screen shared here in a second. All right, pull that all up. Okay, so we're sharing now. We're going to get this pulled up. Should be seeing that okay. So thank you, Kelly, and thank you all for joining me for this today's webinar. Today we're going to be talking about reverse shoulder replacement. And so just so you're aware that the webinar will be available, so you don't have to worry if there's something you didn't catch or something that I went through a little quickly. You'll be able to pause and go at your own speed, at your own time, and review those things. So if you want to take notes, that's great, especially for questions wise. You can put the notes in the chat box. Otherwise, sit back, relax, and hopefully have an enjoyable time when we talk about reverse shoulder replacement today. So as Kelly said, I am the director and founder of the Cleveland Hip and Knee Institute, and as well as a partner with the Gobisi Shoulder Institute. We'll be talking about the reverse shoulder. So first I want to add off that I do have the disclosure that's relevant, that I have received some educational support and some content, some slide content, pictures and educational things from Arthritis and both Medacta USA. So disclaimer at the beginning of this is to make sure you understand this is a generalized overview. This is not the time to talk about personal questions or an individual consultation. First, that's too difficult to do in this environment. And then also for privacy reasons, it's a better thing, and overall to get the best care available is to actually come in for or seek a consultation. So either with your primary care doctor or provider, or obviously we'd be happy to see you in our office to discuss your personal questions. So I'm actually from Northeast Ohio, born and raised. I actually went to Baldwin Wallace undergrad, and then to Western Pennsylvania for most of my medical training, orthopedic training, and I kind of worked through a quad state area. And then came back to Northeast Ohio. So obviously, why do I even do any of these things? Well, because of course I love it. I like being able to help people. That's what I went into medicine for. And I love doing these types of procedures. Everything's kind of rapidly changing in medicine. There's a lot of technological advancements that have really made this a great procedure. So I like staying up on top of that, and it's really fun to be a part of. And I know that we can do, we've been improving and improving our care delivery to people, and things are getting better and better with time. So that's why I like doing it. So overall, what are we going to cover today? Well, first, we're going to just stop off at just understanding the shoulder anatomy, basically, and then understand what's arthritis, what do we treat that, what's a reverse shoulder replacement, and then how do I know when it's time to have a surgery? So first, I'll just start with a little case example. We had a 69-year-old patient that came in to see me. She had very painful shoulder and a really bad shoulder x-ray. You can see here in the center screen. We'll go through all of that. So first off, what does a normal shoulder look like? Well, first, the shoulder anatomy is a ball and socket joint. It's comprised of 3 main bones. The 2 bones here show is the humerus, or the arm bone, and the shoulder blade, or the scapula. There's also another bone, the collarbone, is a clavicle that all joins together and forms the shoulder joint. That's the bony structures. There are also several ligaments and muscles and tendons that cross the shoulder joint and form the anatomy. So there's a big, strong muscle called the deltoid muscle that wraps around the arm bone and inserts or plugs into the arm bone and helps it move it. There's also the rotator cuff muscles, which are 4 muscles that wrap around the ball part and help to both keep that ball on the socket and in the socket and rotate and move that ball. So the ball and socket joint of the shoulder, I like to think of that being less of a socket, because it's not like the hip joint where there's a big bony socket. The shoulder is more like a golf ball on a tee. So the bone part of the socket is more shallow, like a golf tee. That's how I like to think about it. And those muscles that are around the shoulder that help to move it also keep that ball on the tee. And it's really important. The balance has to be right. So if there's a problem with one of the tendons, that can cause that ball to kind of move off in a bad direction, or it can cause the joint to get some abnormal wear. So that kind of ties into, well, what's arthritis? Well, arthritis is something that happens to joints. That literally means inflammation of the joint. Well, the thing that's getting inflamed and causing pain has to do with the joint cartilage. So joint cartilage is the slippery, firm substance that's on the ends of the bones, where 2 bones or more will meet. And what happens is this cartilage can start to wear away, soften, crack, break apart, and become roughened. And that wearing away of that cartilage gradually over time is called arthritis. And so why is that a problem? Well, as that's happening, that causes changes within the bone. The cartilage doesn't have any nerve endings. So the nerve endings within cartilage means that no nerve endings in cartilage means that you can't really feel it. That's why when you're, in your 10s and 20s, you're not really noticing when you move your joints around at all. And you can put them in very weird and awkward positions and nothing really seems to bother it. But as you start to see some more birthdays, then you will start to notice that the cartilage, that slippery, firm substance, starts to break apart, and maybe it gets a little bit softer, and maybe the bone underneath starts to react and get a little bit harder and firmer. When that happens, that bone underneath it, which has a lot of nerves, it's very sensitive to that. So that can cause a lot of discomfort. And that's what we usually see with arthritis. So how do you know if you have it? Well, you get some simple x-rays, particularly in the shoulder. You can see the x-ray on the left here shows a normal joint space. The ball portion is nice and smooth. The bone looks pretty uniform and has pretty much the same amount of whiteness to it. And then as well as you look on the socket side or the shoulder blade side, again, the spacing looks normal, and all the bones don't have any rough edges or ends, and you can clearly make out each bone. As you get to more advanced arthritis, you can see on the x-ray on the right that the space is completely gone. There's big bone spurs and there's roughened edge here. There's cysts, which are dark areas underneath the joint surface or the bone surface. And then there's that white, really bright white, where the joint space is completely gone. And so that's 2 bones that are grinding together. And so those x-rays really are diagnostic, or they really show you how much arthritis is in that particular shoulder. So how does it happen? Well, we don't know the exact reason of most wear and tear type of arthritis. That is the most common. but we do know that it does have some genetic predisposition or something that it runs in families, and that's the wear and tear type. There's also other types. So if you would have inflammatory arthritis, some people have rheumatoid arthritis, gout, pseudo gout. Those things can cause a lot of swelling or problems with the joint lining, and that can break apart that cartilage, and that can cause arthritis, and even earlier in younger people with those types of conditions. Or after you injure yourself, you can injure, fracture, or cause a tendon tear, and that can cause joint pressure changes, and those changes can cause a cartilage to break apart, and it can over time result in arthritis. In particular, in the shoulder, it's important the function of the shoulder and that golf ball and the tee, if you will, depends upon the rotator cuff muscles. So if there's one of the rotator cuff muscles gets torn, that pressure changes can cause a specific pattern of arthritis in the shoulder that we see very frequently. And that is called rotator cuff arthritis or rotator cuff arthropathy, which just means disease of the joint that results because you lose this rotator cuff tendon. And that causes pressure changes, which causes that cartilage to wear out in an accelerated fashion. So how do you know if you have arthritis? Well, some of the symptoms of arthritis is very commonly reported as pain, stiffness, swelling, or maybe you lost some range of motion, or you can't move your arm the way that you used to move. You can't bend it back, having difficulty brushing your hair, or for the women, unsnapping your bra or putting on clothing or a shirt. Any of those things can be signs of the arthritis that can be developing. So what are your treatments for arthritis? So we like to think of in two main kind of camps: is what do we do with not doing any kind of surgery or doing surgery? So operative and non-operative. So non-surgical, there are several medications that can be taken. There's some injections, some physical therapy or exercise, and then changing the way that you do and adapting your lifestyle to kind of meet and to adjust for your pain or your difficulty. So medications, there's various ones. There's over-the-counter like Tylenol, ibuprofen, naproxen, and there's prescription anti-inflammatories like meloxicam or Toradol, and then various topical medications and muscle creams that can be helpful for arthritis-related pain. Injections, there's a few types. Steroid injection is a very strong anti-inflammatory medication that can be injected into the joint space and can provide some significant relief. Then there's the biologic medications that are growing in usage. And we're investigating further on their what areas that are the best to target that. These would be platelet-rich plasma and stem cells. That is something that, again, is becoming more and more studied, and we're getting more information. It's actually a very exciting thing that we're finding with some early results, but more to come about that for the future. Physical therapy and exercise, so things that are targeting staying limber and active is important. Strengthening the muscles. There's so many muscles that cross your shoulder joint that you can target and focus to strengthen and to help adapt. And sometimes we get lazy and we have bad posture. So kind of doing those things to help us maintain our good posture and control can be very helpful. Making sure that we have a good healthy weight. So not being underweight or not being overweight is very helpful for arthritis and overall shoulder type pain, as well as overall body pain and wellness. So lifestyle modifications, making sure we have good healthy body weight, exercise, and making sure that we can switch to some more lower impact type exercises, non weight bearing exercises. So like a pool, the elliptical machines, those have better motion without causing the same pounding type of exercises, can be very helpful. And then we look at this operative type of treatments. For arthritis, shoulder scopes or arthroscopy of the shoulder, making small incisions around the shoulder joint and putting a camera in there and putting fluid into the joint and then trying to scrape out or to quote, clean out the joint, has been described for arthritis. It's not super successful, and it is not a definitive type treatment. But it is something that some patients may be candidates for. I think this is something that's growing less and less common throughout all of orthopedics, especially knee scopes and doing that for arthritis. I know that is something that I've personally gone away from because the benefit is not very high, and the likelihood of it making the problem either not better or worse can actually go up. So it's kind of controversial. That's not something that we really look to do very often. But joint replacement surgery would be the other option as far as arthritis goes. So why reverse shoulder replacement? What's the concept behind it? Why are we talking about reverse? Why aren't we just saying shoulder replacement? Well, reverse shoulder replacement is when we take that ball and socket joint, or that golf ball and that tee, for the analogy there, and we remove that worn bone and cartilage, and we put these metal and plastic implants in there. And the idea is that we switch the ball from the ball side to the tee side, and the tee side to the ball side. And we'll go through that a little more specifically of why that is in a minute. So kind of classically, and what the first thing you think of when you think of a joint replacement is, well, you replace the ball with a ball and a socket with a socket. Well, that is done. That is called an anatomic total shoulder replacement. And that is a very good procedure. It can be very successful for people. However, there's several reasons that we cannot perform that procedure, or that there's risk factors with that procedure failing. And so when you have an anatomic total shoulder replacement, which is the one that's depicted here on the left, this picture here, you're taking that ball and putting the ball on and the socket on the socket side. You have to have normal anatomy in order to have that occur. So you just have to have the wear of the joint surface, and it has to be a wear of the joint surface that is just right, so that you don't have a problem where the implant could fail. And so what's really important is that you have to have a functioning rotator cuff, and you have to have that, like we said before, the muscles of the rotator cuff and the muscles around the shoulder have to be functioning appropriately, or this implant will not function the way it's supposed to, and it can fail. So when we look at a shoulder joint, there's several muscles that cross that. We kind of talked about them before. These rotator cuff muscles, which I highlighted in blue and kind of drew in here. This is kind of simulating where they are, and they attach to the ball part in the front, top, and then over across to the back. There's also a very large muscle, this red muscle, that are lines that I drew over here, depicting a portion of what's called the deltoid muscle. And that helps to flex your arm and bend it, and does a very, very high amount of the motion of your shoulder. And it's a very, very strong and firm muscle, and is intact in most people. And it actually even drapes across this collarbone in the front here, but I didn't want to block our image here and make it too confusing. So for simplicity, just drew out a portion of the muscle, but it covers across this whole front of the shoulder as well. And that's and it wraps around the back as well. So it's a very strong muscle, and it moves the shoulder. So a particular pattern of arthritis that we kind of teased and talked about earlier was when you lose the rotator cuff, and it causes arthritis, it causes that pressure changes. So if that happens, the risk is that this ball part will no longer it won't sit on the tee anymore. That golf ball doesn't sit on the tee as it's supposed to. So that rotator cuff doesn't just rotate the arm and move the arm, it actually keeps that golf ball on the tee. So if the pressure of your arm and the way that your muscles move, what will happen is cause that golf ball to move and migrate, or move and roll off of that tee. And it goes up towards your shoulder blade at the top part. And that makes that not a very successful procedure where you replace that. Because if you try to just replace a ball with a ball and a socket with a socket in this type of arthritis pattern, it can cause that to fail and wiggle out loose. So this is an example of that very thing happening. So what can happen is that this is a shoulder replacement, which is an anatomic total shoulder replacement, where the ball was replaced with a ball, and there's a stem in the arm bone, and then there's a socket on the socket side. And so this person, in this specific example, did not have the rotator cuff intact, or lost it later, which can happen, because that is not something that part of the procedure. It is dependent upon that rotator cuff muscle. If it tears later, this can happen where the ball will migrate up, and that will make it very difficult to raise your arm up after surgery, and cause functional problems and pain. As you can imagine, it can cause the implant to wear out early, which is obviously not a great design. So, well, what if that was the original type of shoulder replacement? So over time, shoulder surgeons learned and said, hey, maybe we can address this in a different way. And around the 70s, there's development of the reverse shoulder replacement. And so what that does is while you change the ball and move it over to the socket side and the socket on the ball side, which we call the reverse, we're going to use this big muscle, this deltoid muscle, which stays intact and does not need the function of that rotator cuff to push down on that arm bone or that ball part. It doesn't need that in order for that golf ball to stay on the tee, because we put the golf ball on the socket side. So that makes this big, strong muscle and the muscles around the shoulder pull and press the golf tee onto the ball. And that allows that motion and that function to happen at that portion. And that we use that big, strong muscle to do the job of the shoulder to move it. And so we're finding that this is very, very resilient type procedure and can last a very long time because of this technique, which is great. And so this is an example of a reverse shoulder replacement, just without the arm bone of the socket there, just how you see how it's assembled. What you have is you start off with a base plate and a plug that goes into or a screw that goes in the central portion into the socket side. And there's several screws that hold that plate on. That ball is then attached to this plate and this post with a screw. And then this arm bone side has a stem that's placed into the arm bone, and that a plastic piece will attach into it and form the socket portion. And so kind of revisiting that example of our painful 69-year-old patient who had a lot of discomfort with the shoulder, tried multiple things, changed her lifestyle, tried to exercise, injections, medications, and all these things weren't working. And she had these x-rays which showed severe arthritis of the shoulder, with bone on bone. So here's a CAT scan of that same patient with that really severe bone loss. And something that happens with these shoulder arthritis is that over time, and in some patients, their bone loss on the socket side will be such that you can't even do the anatomic shoulder replacement or that ball with the ball and the socket with the socket. You can't do that procedure because there's no place it'll wiggle loose on the golf tee side. So when that happens, we plan on doing that reverse shoulder replacement. And one of the things that's really nice is that we have this advanced technology now where we can get a CAT scan ahead of time, and I can plan with three-dimensional planning software and pick out and size what type of implant I want to use, and even plan the trajectory or the angle of my screws, where I want to put them, the size of the implants, and have a really good idea before I get into the surgery what that's going to look like and how that's going to sit down. And it's another check for me during the procedure, so I can see, oh, that's where I want to put that implant, or oh, I should probably get some bone graft available or a specific type of implant to substitute for that. So here's kind of a blown out portion of the socket side. Again, just showing another example of that plate, and there's a screw or peg set in the center portion that fits into the bone. There's a rough surface where the bone end grows into on the implant, and screws that hold that into position while the bone grows into that side of the implant. The ball piece screws into this segment of the plate, and that holds that ball part together. And then there's another example of that all fitted together. So this is a little bit longer stem that's used in some patients, depending on their shape of their bone. And this particular one has an extra little wedge or a metal augment that allows that to correct for any kind of bone loss or the angulation that can happen with the bone. So here's that same patient after we executed that plan that we had. And we were able to get rid of the arthritis completely and place this implant in. And so you can see we've taken the worn ball portion off of the end of the arm bone and put the metal stem in with the socket portion here. The plastic piece you can't see on the x-ray because it does not show up that way, but that's what's in between the space. And then there's the metal ball that's sitting in position. And here's that central post and multiple screws that hold it in position while it's healing. And so with all of that, well, how do you know when it's time to have surgery? Well, generally speaking, when any joint replacement that's done, it's important to try your conservative things. We don't always look for surgery first. There are certain times where it may be necessary if you fall and break something that you need to have surgery, but it's always important to consider what options. And I think about that all the time. I don't just treat x-rays and I don't just treat images, I treat people and not just body parts. So we always have to consider what are your other factors. And that's why it's important to seek a consultation in office and to talk to patients and kind of see what is going on in their life and what's their other medical conditions. And we make decisions for surgery based upon all of those things together. We make it together. It's not me telling you. We make a shared decision. What's the best for you? And that's how I approach my practice. And that's what we do here at the Gabisi Shoulder Institute. So friends, family might also be able to help clue you in, like, hey, a lot of times we're not paying attention to how things are affecting our quality of our life. You don't realize you start to modify things so much where you're no longer doing the things you like to do, be it tennis or golf or swimming, or your friends or family will be like, hey, you haven't been to play golf in the last 6 months. Like, what's going on? So they may be able to help you out with that. And then I think you always have to look at yourself and just really think, to yourself and say, how is this affecting my life? And so part of that, just mindfulness and considering, like, what are the things that I'm not doing that I may want to do? Am I seeing my grandkids, or am I seeing my friends? Am I going out to the course, or am I going to play tennis or playing cards? Is this limiting those types of activities? Well, that might be time to start thinking about, this is a time to consider a surgery to help you out with that, because you don't have to live like that. So overall, I look at another thing I use for joint replacement surgery, was taught to me by my trainers, was to look at kind of the calendar test. And so a quick way to get an idea of like where you're at on your pain is if you look on a calendar, a day-by-day calendar, and you write down if your arthritis symptoms and track them and say, hey, how bad is these symptoms today? You either put a smiley face if it was not a bad day, or you didn't have bad pain or no pain at all. And then you put a frowny face if it was impacting you or if it was painful that day. When you look at the month, there's no magic number. But certainly if you look on the calendar and it's about 25 of the 30 days is frowny faces, then the question is, what are you waiting for? We can do better than that. If you're only like 2 or 3 frowny faces, well, maybe it's not quite time yet. Maybe we need to consider some other options, or there's other things we can tweak that can make things better. It's just kind of a generalized thing. So overall, just wanted you to take home, what is my main mission? I want to provide the best care I can for patients. I want you to get back to your quality of life. I want you to do what you love to do. I want you to get back with those grandkids. I want you to get back to the tennis court. I want you to go back to swimming. So I think we can get that accomplished. It's just always we have to make this personalized. I think it's something that we try to tailor it to each specific person. So my overall philosophy is to respect the anatomy of the body, try to use minimally invasive techniques, and I believe in rapid recovery joint replacement surgery, which means I like to get my patients up and going, and I like to get them back to doing the things they love as fast as possible. And in particular, I try to get my patients either home the same day or the very next day from surgery. Obviously, there are certain exceptions to that, but I'd say the majority of my practice is in that category. So the different techniques that I do reverse shoulder replacement. I also perform kinematic total knee replacement, partial knee replacements. I do anterior minimally invasive hip replacements with a bikini skin incision. And I have several videos that are on our website that go over several of these topics. And you can look up that. I'd also like to do a quick plug for our PT Genie and Genie Health application. I have a whole another webinar on that too. And I sound like the podcast guy. Like I'm like, oh, I listened to a podcast about that. So I have a lot of these webinars I'm starting to build out. But at any rate, this Genie Health is something that's really fabulous. We've been able to, Dr. Gabisi, my partner, helped to develop that application, and I've been using it in my patients, and he's been using it in his patients as well with some tremendous success. It's something that allows you to do home physical therapy in the comfort of your own home. It guides you through the exercises. It's a personalized plan. And we frequently use this with a hybrid approach where we have physical therapists that you can come and see and use these exercises to help guide your recovery. And it's just a great program. And so I just wanted to give you a heads up. This is something that we do use, and it's something we offer that I think is pretty exemplary. And since I joined practice with Dr. Gobisi, I've been really pleased with my patients being able to use this platform. Certainly is really I think helped my practice go to the next level. So we are at the located at our new office location, which is at the Cleveland Orthopedic and Spine Institute. And this is our new building. You can plug in these directions. I think some people have had a couple issues with maybe the Google Maps directions. I don't.
We're
I've
still
never
working
seen
on
that
yours.
problem.
Yeah,
What's that?
we're still working on your Google Maps. It's
Okay. I think there's something, yeah, Kelly's been spearheading getting that resolved, but I use Apple Maps, and maybe it's just because I'm using Apple Maps, it's never been a problem for me.
huh.
Um,
Okay.
so that might be something to look into if you don't have that on your phone. Obviously, Android devices, you may be able to use a different one like Waze or something. There's different navigation apps, but I know the Apple Maps works fantastic for me. And it's never seemed to steer me wrong for that. But if you ever have a problem or concern, please don't hesitate to give us a call. We're happy to get you to the right place. We want to see you too. We want to make sure you get to our office and be able to see us. So there's some of our references. And now's the time I'd like to open up for questions. Again, I want to before I do that, I want to do a couple of ground rules. Again, just a reminder, friendly reminder, please don't ask any personal questions because there's privacy issues with that. And also, it's just not the appropriate format. I'm happy to see you in office. I'll spend as much time as you want, and our nurse practitioners and PAs will spend as much time as you want talking to you and answering all your questions. And then just remember, please put them into the chat in order to do this so we can Kelly will make sure we get through all of those things. And then, of course, if can't think of any right now and you think of them later, we'd be happy to see you in office, or if you want to give us a call, happy to go over any of those questions. So Kelly, any questions?
Yeah, there's a few questions. That was great, Dr. Callahan. Thank you so much. The first question for today is, are insurance companies covering reverse shoulder replacement?
I'm sorry. I'm sorry, Kelly. I caught the very tail end of that. It was you said the coverage.
Oh yeah, insurance. Is insurance covering reverse shoulder replacement?
Yes. So reverse shoulder replacement has been successfully performed in the United States since it was in the 70s or 80s.
70s, yeah.
That's been going on. And then it really became extremely popular and has grown, and we've advanced it since the 1990s. It has been a covered procedure for as long as I am aware of. There are certain reasons that you would want to make sure that it was communicated that why we're using this implant, as far as insurance companies want to see us saying that's the case. But to be frank, that's how you practice medicine. You're supposed to explain why you're using an implant anyway, why you're doing the surgery to begin with. And so it is covered by insurance. You should know that I think that's a common thing that we can run into issues or difficulties, is that when you say covered, you need to understand that your insurance is very specific to whatever your personal circumstances are. So there are certain insurances that require copays, and whatever your copay is depends on if you have co-insurance or not. You may have a higher deductible. All of those factors can maybe be a part of why you might ask that. They are covered, though. It is covered by insurance, the procedure. So hopefully that wasn't too much of a answer, but yes, it's covered by insurance. You just need to know the cost and the expense has to do with the way your plan is structured, but that's true of any other procedure that you would have.
Great. Okay. Our next question is best case range of motion for a golfer after reverse shoulder replacement.
Oh, great question. So,
Yeah.
So golfing. I'm gonna answer that question and give you a bonus answer, because this is something that people want to know that are golfers all the time. So first off, the best case scenario has to do with one of the predictors of motion before surgery is what you have before surgery also helps predict what you're going to be like after the surgery. But most people make tremendous gains in their shoulder motion after reverse shoulder replacement. I can't tell you the exact degrees that you're going to get back, but we do strive to get people back to the ability to golf after surgery or after reverse shoulder replacement. So that timeline, usually we have a very specific, that's why we like that. I like that Genie Health has plugging that. And our physical therapists who use our protocol know this. We have a return to golf protocol. And that starts around the 10 to 11, 12 week mark approximately, that we'll start engaging in that to get back to the golfing, like full golfing. So there's an actual graded program for that we have developed. So yes, people do go back to golfing. I recommend any joint replacement, because I do joint replacements of shoulders, hips, knees. Any joint replacement, whatever you're going to do, a newer activity, is to grade into it, like ease into it. Start off with light things. So for golfing, that would be like go to the driving range before you go to the course, and do like your wedges. So start there, like putting and chipping, and do it very lightly. You know, if you go up and grab your driver and start wailing on it, then you're on the course and walking 18, you might be a little sore at the end of that. So I usually tell people to kind of build back up to that before when they start to do that. But golfing is absolutely permitted. We go back towards that. And again, those are guidelines that are generalized. It may be more specific to your circumstances. You might be a little faster or slower. It just depends, your personal circumstance.
And then someone asked about range of motion with pickleball, returning to pickleball as well.
Yeah, so it'd be the same concept. The pickleball, although I'd say we probably need to develop a specific pickleball thing since that's so hot right now. That sport is exploding right now. So it's so interesting how that happens. And that was a big deal with the CrossFit became really big for a while there, and we started to see a spike of that, and then unfortunately we started to see a spike of injuries that are associated with any new activity or sport. So it's something that it can happen, but I think it's a great thing, keeping people active. So, but yes, range of motion for pickleball. Yes, I am okay with people going back, and we do have people go back to playing pickleball after shoulder replacement surgery. But again, it's all about, following our protocol.
Great. Yes. And I know they're building indoor courts all over Cleveland, so that's exciting.
Mhm.
So the next question is rehab for reverse shoulder versus rotator cuff repair. What's the difference?
That is a fantastic question. It's almost like a planted question.
Was it? I didn't plan it. It's real.
That's a great question. So yes, actually, ironically, because you would think with a shoulder replacement that the rehab would be much more difficult than a tendon procedure where you're fixing a tendon, but it's actually the opposite. The recovery for a tendon repair, because we need the biological tissue to heal into the bone, the tendon into bone, you can't really speed that process up. So we do have to protect the repair. So you're generally speaking about good 6 to 12 months for that tendon to fully heal. And I usually I am conservative on that. And as far as the tendon healing, that you need that time to let that to fully mature for a rotator cuff repair. So the rehab and the protocols are, you're in a bump sling for about 6 weeks for a rotator cuff repair, because we need that biological healing. The reverse shoulder replacement, you're in the sling for a few days, and then you start to come out of it. Once the block wears off, you start moving your elbow, wrist, and hand. As soon as you start feeling the sensation back in your arm, and then we graduate your protocol. Usually within the first 2 weeks, you start to really begin your shoulder motion. And then people will take off on that and do really, really well pretty quickly. So the recovery is, in my opinion, in my practice, it's ironically a little it's so much faster with the reverse. It doesn't mean that you should just have a reverse all the time. There are certain times you should consider the rotator cuff repair. It's just if there was any reason to be between the two. The recovery for that's a discussion personally I think we have to have in office.
Great. So our next question is this. I've never heard this question before. Can steroid shots for pain cause thin skin?
Yes, if they are injected, if you're a very, very thin person and the steroid does get into your skin level, if you are, those are the people who are the most risk for it, is extremely thin patients. Steroid can, especially chronic steroid injections, or any steroid therapy, if you're taking oral steroids, the same thing can happen. It can cause the skin to get a little thinner. So it is a risk with injections, but it's in medicine, there's always a trade-off, right? So you rob Peter to pay Paul. That's the way I just use that saying to describe what we're doing, is that there's always a trade-off. So there's a risk benefit. I don't like to inject more than 3 or 4 times in a year into any specific joint or spot, because of several reasons, but one of which is that it can cause your skin to get a little bit thinner, and in people who are darker skinned, particularly if you inject a lot into that area, especially right under the skin, it can cause the pigment of your skin to decrease a little bit. So that's something that's important to make sure you try to limit those things.
I didn't know that.
Mhm.
Another question is an attendee says when they apply heat to their shoulder
Mhm.
or get a massage that gives them some relief, is that normal, or is that sign of that they may not need surgery? I
No,
think
that's a
that's what
very
they're asking. Yeah.
That's a no. The heat can be a very wonderful thing, particularly like moist heat can loosen up joints. So one of the main symptoms of arthritis is stiffness. So that heat and that moist heat, particularly, helps to kind of loosen up the joint and make it feel a little bit more supple, which lets it move a little bit better. But obviously, there's a limitation to how much you can use. How much that's going to be effective. But that's why you're absolutely right. You've discovered something that's very, very true and very helpful for arthritis pain, is that heat can be helpful. It is not a good idea after you've had a shoulder replacement to put heat onto your wound early, because it can cause a lot of swelling. So there's kind of a balance with that heat. So usually I'd say most people, if you're having joint related pain, and it's if you're arthritic, heat can help you loosen up to do something. So if you're going to go do an activity or something, you kind of use that moist heat, kind of loosens you up. You can do the activity, but then after you're done with the activity, when it's kind of sore or achy, you can use some ice to calm it down. If you're swelling particularly, that can help out with that.
Okay. I have a dog groomer question. A person here is a dog groomer, and she's just asking how long it would be before she could go back to work. I don't know if that's similar to playing sports or not.
Yeah, I guess it depends. I mean, the specific circumstances of how much. I mean, are you? I'm not a dog groomer. I don't use it as my hobby or anything. So I don't know the exact things you would specifically do. You'd probably be best to ask an office, so we could go through specifically what's required. So before I'd say definitively, oh, it's this number of weeks, it'd probably be important to know how much lifting is going on. Because are you picking up these big dogs, these big like bull mastiffs and stuff like that, or one of those big dogs, those Newfoundlands and stuff. You're lifting those kind of dogs and like having to wrestle with them. Well, that might be maybe a little bit longer. But if it's something where you have an assistant helping you, then it might be a little bit sooner. So it's hard to tell. It depends on the specifics. But certainly, I'd say most people are able to go back to most work related things by 12 weeks. That's almost with some rare exceptions. I'd say most people are at that point, are very, very ready to do most activities, but it could be even sooner than that. It just depends on the specifics.
Well, that leads us to our last question that I have here is any weight restrictions after full healing?
Yeah, so that is a great question,
Yes.
because that's one we get all the time, and it's really, really important when the bone is healing, because those implants, we kind of alluded to it a little bit, and talked about it, showed that they have that rough surface. That's where the bone grows into the implant. It's really critical to allow that bone to heal in there. That takes a good 12 weeks to really happen. So you want to limit the amount of weight that you're doing in that that arm while it's allowing it to heal. Because if you push it too hard, you could actually cause a bone fracture because the implant could wiggle loose or it could break. And those are pretty terrible when that happens, and it's not always able to be fixed. So it's really important to not push it too early. Once you do heal it, and once you have that healing, I would say that you can do pretty much whatever you feel comfortable with. I I always like to say I didn't make you Superman though. Like it didn't make you able to lift things that you weren't able to lift before. So don't feel like it's like gives you the new like you're indestructible, right? So understand you still keep all those other things. Your muscles are, pretty much the same muscles there. So you're not gonna all of a sudden be able to lift a truck or do the strongest man competition. So not a good thing to maybe pick up after the surgery if you weren't doing it beforehand. Or like the golfing. People always ask me if I'm a golf. Like, well, could I golf afterward? I'm like, I don't know. Could you golf before? Because I don't make people into golfers. I'll allow you to go back to that activity if once you heal it.
Oh, well, that's great. And then I got one more question here. What about driving? Back to driving. I don't know if that's for long periods of time or.
Yeah, great. Another one. These are great questions, guys. Everybody, thank you. These are really, really good questions, and it's probably some of the most common questions I get in office. So it's a good. You guys are right on the money with these questions. So the driving, driving's a matter of safety, common sense. Like I just said, I can't make you into a legal driver if you're not one before. If you don't have a license, you're not allowed to. But it's seriously the medication. So you do get medications after shoulder surgery. One of which we do prescribe to some patients or most patients is a pain medication. And that particularly an opiate pain medication, while we try to minimize the amount we do, it is still something that you may or may not take after the surgery, depending on your discomfort level. That is illegal to drive in the state of Ohio or in pretty much everywhere else in the country while on those. So you definitely cannot drive during that time frame. I'd say most people it's a few weeks after the surgery and they can start to feel comfortable, but it's a matter of safety and common sense. Almost every joint replacement I've done, I'd say the overwhelming majority of people are back to driving by 6 to 9 weeks. But it's a personal thing too. So if you feel comfortable enough to, then generally you'll be safe to do so. You just need to give yourself extra distance and time. So you're stopping your reaction time when something happens while you're driving will be a little bit slower. So usually take somebody with you the first time you drive, or if you're going to go to a parking lot and try out, and see how you feel with it. And that usually is some safe guidelines to say, hey, okay, I'm comfortable enough, or no, I need a little bit more time. And then of course, if you're using like a stick, or if you're manual, you need to you have to consider that as well.
I do have one more question, but it's very specific to this person. So I feel like, Kate, you should come into the office and talk to Dr. Callahan. Bring your MRI results probably with you when you come in and make the appointment. But there was a very specific question about someone's shoulder. So yeah, I'm just going to let that person know that they should come in and see you.
Yeah, I mean, again, I don't want you to feel like we can't answer that question. I'm absolutely happy to do that. I would love to do that, and we love doing that here and talking to people. It's why we like to protect everybody's privacy, and of course, to do that. So, but we could definitely do that and probably give you more information than you even expected if we have an office visit. Okay?
Yeah, great. Okay, so she heard me. Okay, so this was great. This was the best one yet, I think.
With it. Yeah, so thank
so
you.
Yeah.
Thank you, Kelly.
And thanks everyone for coming. I'll let Dr. Callahan wrap it up, but we will post this on social, and I will email each of you a link to it within the next 24 hours, and look for it in your inbox.
Yeah, thank you so much for your time and attention, everyone. Thank you, Kelly, for helping set this up and put this on and broadcast it and get it out there. Again, I just want to thank all of you for coming in and your attention. I look forward to seeing you in the office soon, or out and about, and maybe out on the golf course or the pickleball course. I guess that's the new thing. So maybe I'll see you out there. Have a wonderful rest of your day. And again, look forward to seeing you soon.